Right, okay, so the preface that we want to make is that we are talking about the future, okay? We have kind of turned the bed cover upside down, and we want to start about talking what is the future, which is not going to be better, it's not going to be worse, it's just going to be very different for everyone. And what we want to concentrate on is how will post-COVID-19 future for our doctors be, because this is very, let's say, important and crucial for our business lives. We shall talk about one thing that you as salespeople, sales supports, will have to turn off your way of being and turn on a different way. And the different way is you're not going to be a salesperson for your customers from, let's say, tomorrow onward. You have to be their consultant, because this is what they actually need to have, because they are in trouble. They don't know how to act, because their professional life is actually very, very different from the day of opening up. We are going to bring on some, let's say, examples of what we are showing to you, that it's not that we want you to be our guinea pigs. We want you to be simply aware that what we are talking about today, it's already happening in countries that happen to be, you know, quite substantial ones in terms of, let's say, presence worldwide. And I'm talking about US, America, and I'm talking about Italy, our homeland. Now, I take that you have been, all of you, already on the webinar that Professor Stonecipher ran a few days ago, which I shared with Fergal. And therefore, I think that you already have a good idea of what doctors, you know, are living nowadays. Okay, so what happens now is the life of doctors, eye surgeons, but optometrists as well, because your country is one of the fortunate ones where they can do most of things, are facing necessary procedures, which are very different from before. We have been talking about this subject with many people, and a matter of fact is that the number of people, of patients that can be appointed, or rather they can take an appointment in the same as before, has gone. There's no way, no possibility to have people in the waiting room. So it's going to be one by one. The procedure to get through the approach to the patient, it's also very detailed. You have to disinfect the patient, you have to dress the patient, you have to be prepared as an operator to actually wear the gown, wear the mask, and of course, all the instruments have to be disinfected as well. So all this preparation tells what? That the habit, it's changed. And we are going to have one-to-one, which means one patient, 1 hour invested on that one patient, which actually does what? Many more patients, many less patients, but also automatically less earnings. Is one thing to have one patient, is different things to have 5 or 6 normally within an hour. So the overall scenario is completely a different one. Okay, so what is this going to mean, let's say, for our customers? That they are facing, let's say, a situation that easy to understand. Doctors, practices had X number of people that are now at risk to be retained because the situation has changed for everyone, not just for the doctors, but also for the patients. And therefore, on one side, We have doctors that have the great need to retain the people, the patient park that they had before, and possibly attract new ones. And those ones that they can't think best, they do what? They choose the fast track. They think that it's a fast track, the low price, lowering pricing, applying discounts. But that is a lose-lose situation, not a win-win situation, because it does not take, let's say, anywhere other than lowering and lowering and lowering more. On the other side, we have the patient that has its own built life, working life, that in many instances, unfortunately, has been under an earthquake, and therefore even financial means of patients have changed, and therefore they evaluate, everyone evaluates in a more severe way their lifestyle, and healthcare, incidentally, is part of that, because dear money paid for healthcare that is, let's say, not optimal, it's already, let's say, a concern. So what do they want? They want more for less money. Again, it's a cut in the income of doctors. Therefore, we are, let's say, facing, a couple of, let's say, possible strategies. Our doctors have to think in a different way. And therefore, they have a couple of choices that can be on a defensive or on a proactive way. In a defensive way is if they choose, to lower this cost, it's going to be dramatic because it's a race downwards, and there are not going to be any winners at all. On the other side, if they do, or if they choose a proactive way, then they have to be different from what they used to be. Otherwise, the patient is going to judge, well, this is not different from before. Therefore, they have to actually raise the bar of their professionality, and therefore maximize the fact that they already have gone through all that harassment of preparing the patient, cleaning, especially the instruments, dress up the patient, dress up them, themselves. And therefore, to maximize that means that they have to be, let's say, different from before, different from the competitors, therefore the other doctors, and therefore be able to gain a little bit more money. Because remember, if before in 1 hour they had 4 or 5, now is 1-to-1. So they have to maximize that patient at the best way they can, in the best way they can. Now, the winning strategy is that every doctor, whether they do refractive surgery or cataract surgery, or they just only do contact lens fitting, or the optometrists, they do all this preparation to surgery. These people are actually, let's say, the sight professionals, and therefore the core business now needs for them to have means to be different. This is why we have put together this, let's say, acronyms of I like philosophy, because with this, let's say, indication, we really want to indicate a project that actually means and signifies a different opportunity for their future. For the professional, our customers, our common customers. And when I was saying that this philosophy, it's not new for you to be our guinea pigs. This philosophy is already being tested in these big markets like US and Italy. And therefore, US with Professor Stonecipher, you've heard it, yourself, that he does, let's say, this concept of pre-treating the patient before his surgery. Professor Buratto in Italy, he does exactly the same, and he is very, very happy because he's obtaining a much rewarding post-op result. Other places, like, for example, Dr. Pult in Germany, one of the most, let's say, squared out markets and very strict markets, is already opening up to this situation. Professor Geller in Italy, that actually is an optom, and he's also applying this in his managing CLD, contact lens discomfort. And therefore, this, let's say, that we are talking about, it's not an experiment. This is a consolidated and working, let's say, approach for tomorrow. Now, the eyelight philosophy actually belongs to a overall consideration that we have been learning from who? From the doctors, because from them we heard well the cry out of dissatisfaction. We heard well the patient that suffer drawbacks after surgery when they were expecting this surgery to be very, let's say, a resolution to their problem, whether it was a cataract or whether it was a myopia. They expected to have a very good result, and they didn't, because there was something missing. And with this project, with this philosophy, with eyelight philosophy, we want to bring you the means of going to your doctors to offer something that they really are interested in hearing. They don't want to hear about nuts and bolts, about a slit lamp or mechanic problems. They want to hear solution to their problems, because these problems they've had for quite some time, for some years. Therefore, what we would like to drive you through is, what are doctors really saying? Because, or rather, to find the reason they cannot obtain a perfect vision for their patients. Well, so we've been kind of nosing and putting our nose across publications by people that are highly respected on the ophthalmic scenario. So the names that you are able to read here most definitely are easy to be recognized. And if we just, let's say, read quickly through, we can see that for example, Professor Labetoul in the French Journal of Ophthalmology wrote that unresolved ocular surface disease represents a major risk factor for a suboptimal outcome in refractive surgery. If you don't treat dry eye disease and meibomian gland dysfunction, the impact of the accuracy of the calculation of your surgery, it's actually going to be a poor visual outcome. And therefore, the dry eye disease, asymptomatic and symptomatic, can actually be increased, during surgery. And then, of course, post-cataract, you have a dissatisfied patient. We have Professor Kochner, the former ESCRS president, that in Cataract Refractive Surgery Journal 2018, she actually, and the survey in Eurotimes December 2019, Professor Filomena Ribeiro, they say that in people with unstable tear film, there may be a variation of even 1 diopter. So this miscalculation, it's actually going to be, let's say, a magnitude of error, because the patient is not going to be a patient that can throw away his spectacles, his glasses. Then we have even TFOS in 2017, but we have people writing also on cornea in 2012 about the need to actually there's a high percentage of people that actually have dry eye symptoms even before they undergo cataract surgery. And therefore, if you have such a diagnosis, more than half of these people actually are candidates for refractive and cataract, but you have to postpone that. Jose Duell, PhD, the survey of 2018 of the SCRS, he clearly talked about trend survey revealed that the vast majority of respondents agreed that mild to moderate dry eye significantly impacts keratometry and intraocular lens calculation. But routine examination of ocular surface is inconsistent. This is very serious. I mean, this word is very serious because 84% of respondents routinely check the ocular surface in all or most of the preoperative laser correction examination, but only 76% perform an ocular surface check during the preoperative cataract surgery examination. And actually this suggests that the cataract surgeon will then deal with a significant ocular problem, around about 40% of their preoperatively or both pre-op and post-op. And this is a very serious outcome that, remember, brings that patient back into surgery with all the problems that we have seen at the beginning. This rarefication of being able to see people, money that you spend on people, on patients to re-prepare them for a second, let's say, examination after surgery. So at this point in time, we asked ourselves, what should be done? Because if there is a problem, it is obvious that we have to bring on a solution. Again, Professor Kochner tells and writes that it is important to detect, diagnose, and treat OSD prior to surgery. And the benefits of pre-treating meibomian gland dysfunction on keratometry prior to cataract surgery has been demonstrated. 88% of patients in well-managed NGD were within 0.25 diopter of refractive target, and 92% were within 0.5 diopter, which is a very good result. Moreover, Professor Labetoul from France says that there is a clear need to encourage preoperative assessment of the risk of DED development or of worsening in all patients as a routine approach to cataract surgery. The majority of cases, he says, 80% or more, presenting for refractive surgery. Only an estimate 2 minutes is required to assess an ocular surface, and only 5 minutes in patients who are in greater risk of DED or have existing symptoms. More, an unstable tear film leads to inaccurate or non-repeatable preoperative measurements. Robust assessment is recommended in all patients who are candidates for cataract surgery. So he tells us very clearly that this population is to be helped before cataract. More, Filomena Ribeiro from Portugal in the Eurotimes survey, December 9, 2019, says that the awareness of OSD in cataract surgery candidates is critical to optimizing post-op outcomes, because the tear film is a very important component of the ocular power. Effective early management of OSD will improve pre-surgery assessment, increase accuracy of the IOL power calculation, and help reduce complications associated with surgery. The management of OSD in the pre, peri, and post-op phases of cataract surgery will definitely contribute to more stable vision and greater patient satisfaction. Again, Kochner tells us that patient expectations from cataract surgery are higher than ever, and most physicians should resolve DED to contribute to patient satisfaction after a refractive procedure. Unresolved OSD is likely to lead to suboptimal post-op vision quality because preoperative calculations were inaccurate. So this cry out is definitely a very serious one, and this is what actually, what we kept and looked very, very careful, in a careful way, to actually take out a protocol. How can we help medical profession sight professionals to actually be able to obtain a perfect vision. They need a protocol. We need to be able to offer them a protocol. Having heard everything that they have to say and to complain about, this is what we have to help them to set in place. In doing what? Do a first step, which is this screening, this evaluation of the pathology that those scientists, they already taught us that we need to help them resolve. So we need to do a DED, a dry eye disease screening with an automatic OSDI-6, a questionnaire. Then we need to do the screening, an MGD, and we have 2D and 3D mammography available in our portfolio. We need to do an evaluation of the pathology level. And here, Dr. Pult with his Maple scale comes into aid, but we have increased 12 sub-levels to that to be even more precise in the level of that MGD Maple scale indication. Altogether, although the discussion takes longer, altogether it takes 3 minutes. And this is also a very important aspect to be kept in mind. Then we go on to step number 2, which is we have identified what the problem is, then we have to treat. And therefore, the pathology level that we have obtained from our instrument, it's actually entered into the software of the treatment device. And then the software automatically sets the parameter for each single patient. And here we talk about the mask. The LLT mask is then applied onto the patient for 15 minutes. And this is our pre-surgical approach. Then from this point on, the doctor can actually go and do the surgery as he had planned to do, whether it is a refractive or a cataract or whatever else. So this is the, let's say, summarization of how we see our customers have to change the approach, but they can only change their approach if we help them to see that there is a solution to the problem that they already know they have. And those, let's say, extrapolations that we have taken from different people tells clearly that they know they have a problem. So we need to help them solve it. Okay, so we have seen that the exam will take only 3 minutes and the application of the treatment, it's only 15 minutes. So we have no super, let's say, dedication time, especially because in this no time commitment that we have identified as a, let's say, strong mark, the operator is off, let's say, duty, in the sense that after the first test done with the MeCheck, then the application of the treatment, it really is handless. The patient has the mask, period, but the operator can do something else at the same time. Likewise, we don't need to go in with a hammer and bricks, to build new offices in our clinics, simply because the instruments that we are talking about do not require any, let's say, super organized extra space in their clinic environment. MeCheck doesn't even need an electric power because it is alimented, powered via the tablet. So we don't need to be by the wall or by a socket. And the patient sits in a normal reclinable chair. So we don't have a need for a bed for the patient. So everything is really light in terms of organizing examination and treatment before surgery. Carrying on. In this way, we do, let's say, show and we can provide a maximum outcome for the operator, and not only, because at this point in time, he will have all those risks that we have seen before said and spoken by the doctors. We have here an optimized main surgery, and we take off all the risks that they were identifying for us. We have then a final surgical result, which is refined, which is educated, so to speak, plus the doctor has been able to set in place an innovative protocol for their patients. The patient will be able to even identify that there is something different from what it used to be. And so he will realize that, first of all, he has made a very good choice for his money, because he will then have an ideal refractive result, whether it is cataract, whether it is refractive surgery. So the patient will be, let's say, a gained patient that will most definitely even traction other patients to the same clinic, the mouth-to-mouth wording. And the investment, let's be very open. I mean, we are all part of the industry, and what scares the most a doctor is to think about investments at a time in which he has seen his income reduce dramatically because of the lockdown. And therefore, nobody wants to listen to, oh, spending money. We have to show them. You have to show them. Here, you really have to play the consultant part, because showing him that a MeCheck system can really be obtained for as little as or less than €100 per month. Of course, I'm talking about a 48-month lease. And that is, let's say, no investment, so to speak. An iLight, which is the full, let's say, product, the treatment equipment, also can be obtained for less than €550 per month. If we talk about a Mabel mask, which is the new baby in our family, that also can be obtained with a very reasonable amount, which is less than €350 per month. So altogether, what we have to concentrate on in approaching our customers is certainly not to talk about 1,000 plus cost of the unit, but make him realize, make your customer realize how light and easy to recruit the investment with a lease that he normally would do for any equipment. And do remember also, Professor Stonecipher's marking out how much he charges for his patient. If you recall what he was saying, he was talking about $350, euros, it's almost the same. So $350 or euros per session. I think, it says it all, in the sense that you need one patient to actually work through recovering and redeeming the cost of your monthly investment. So altogether, we are certainly not, let's say, asking your doctor to be, let's say, putting out heavy money. Now we do start talking about what we have and what we offer to our customers. Now, our MeCheck, that to some extent you all know, has been, let's say, subject and object of lots of improvements. And we have added many features that you can see, outlined, and I already have anticipated, to some extent. But the most important thing is that it is the one and only instrument that in 3 minutes provides you all the information that you want and you need to have about the ocular surface. Do remember what the doctors have said in their papers, that you need to take care of the OSD, so the ocular surface, to actually know and learn what you actually need to know before your surgery. So we have added, yes, a 2D and the 3D images of the meibomian glands. Now there is an automatic detection of the gland with the calculation of the loss percentage. As I was explaining, the 4 Pult Maple scale level have been, let's say, evolved with 12 sublevels. So each level has 3 sublevels, low, medium, and high, so that we know where we actually stand in our evaluation. We have a qualitative analysis of the meibomian glands. We have the automatic OSDI questionnaire, which you already know from the current MeCheck version. We have infrared high-quality images. We have Demodex screening. And this is also something that will add a further, let's say, tool to the doctor to actually assess best the patient condition, the patient situation. Magnification is the highest, from 50 to 1,000 times you can see the ocular surface with white light. You can actually see vessels in a much, let's say, greater way that you would expect. Then we have my mask, which is the one and only approved photobiomodulation system to treat dry eye or NGD. Now, light modulation actually is capable of triggering a biophysical reaction. We stimulate cells to make a better protein synthesis because we nourish the mitochondria. If mitochondria is well fed, then there is ATP that actually is created, so the cell works much better. As a result, the glands are actually functioning in a better way, rendering, let's say, the operativity of the doctor much better, and the eye, of course, much more fluent. And it is a 100% automated treatment. Now, you notice here that the design of the mask is different. It's lighter, it's more powerful. It's, let's say, part of the face is being, let's say, uncovered, so that we have, let's say, eliminated some complaints about, let's say, being too heavy or claustrophobic. And therefore, in this, let's say, post, or rather still COVID-19 timing, this is a very, very good, let's say, tool to actually take care of a pathology, of a trouble, without almost even touching the patient. So this is a super tool, I would like to define it. Then we go on to the full system that you already know, which comprehends the 2 technologies, which is OP, the IPL traditional light, traditional yet unique, because we do not use gel, as you probably all know by now. And then we have the other technology, which is light modulation, that I was talking a few minutes ago. And this indeed renders our offer unique in the world, because we can treat both eyelids at the same time and both eyes at the same time. Nobody else can do that. No matter what they say, IPL in the upper eyelid is cumbersome, is not, let's say, a performing thing now, especially now in the COVID area. And therefore, with this application of the mask, we are actually capable of really providing 100% treatment to the eye of our patient. Then we go on, and the new baby. The new baby, it's actually an innovative system to actually solve the most important pathologies of the eye surface. Of course, we're talking about dry eye, chalasia, and many of you have seen already what can be done with our mask, with our technology on chalasia. We can do blepharitis, even Sjogren's syndrome, post-blepharoplasty, and so forth. Mabo mask, this is the brand that we have given to this instrument, actually treats in a customized way the severity level of the MGD that has been detected onto our patient. And the correct amount of energy and treatment time is released, again, via the mask, and again, almost without touching our patients. And that's absolutely very important nowadays. Now, I really would like to take you through what I was saying before, that this, let's say, new protocol, it's definitely not, let's say, a trial. It is something that in the hands of people like Lucio Buratto is already a consolidated fact. And he writes, this is an Italian magazine, it's called Eye Doctor, that of course we have translated for the purpose of everyone understanding it. And if you look at the last part, he does already treatment with the LLLT mask in the pre-operating theater before operating on his patient, whether it is cataract, refractive surgery, or other eye surgeries. And especially in those patients that are asymptomatic, it is difficult to make the patient understand that he has a physiological problem that needs to be set right, otherwise he's going to be in trouble afterwards. And therefore, he has instituted this protocol that systematically he does an application of the mask before his surgery. And he has turned down the, let's say, post-op problems that he had for quite a long time. Buratto is one of the constellation refractive surgeon of the world, and he has seen a tremendous decrease in post-op troubles. The patients were going back and were complaining because he took away one thing, but then he triggered another one, which is dry eye. Then, of course, we have our American side, let's say, Dr. Stonecipher, Professor Carl Stonecipher, that actually has published those two papers in clinical ophthalmology, creating a, let's say, a clinical support, which is, in our perception, phenomenal, considering the amount of people that he has treated in a very short period of time. And I'm talking about the 460 eyes out of 230 patients with a very high and interesting result. But even more so, the most astonishing result that he has been able to see has been using the mask on chalasia. All of this has brought him to actually acquire the application of the mask prior to surgery. You've heard it. He did that also on his mother-in-law, and he really loves his mother-in-law. Otherwise, he wouldn't have done the treatment prior to. Because it is so effective, he actually does it to his patients. And these are the two, let's say, parts of the world that are really taking this approach on. And Carl Stonecipher is a strong dragger, and the webinar that you have been watching actually had more than 750 people enrolled, and they were all doctors. And the interest, that he's raising, it's really, really important. Then if we go further, we will see that this is Pult, the only English part that is being published on Die Kontaktlinse, which is a German magazine, talks also what ODs can now afford to do. You know that Germany is one of the most strict markets and mentalities, if you want, allowing optometrists, to do anything. But because Pult has this, let's say, level of let's say physique du rôle within the TFOS society, he made this study saying that LLLT treatment, it's definitely brings on a much better result for the patient. Then I'd like to propose to you some more examples of people that, well, besides being your, let's say, colleagues from Spain, these doctors have all related at congresses, Spanish national congresses, their results and their impression that they've had using the iLight product. And I'm not going to list it all out, but it is quite clear that each one of them found reasons to actually have, let's say, a very good reason to actually walk hand in hand with our product. Moreover, it's even before that, this is 2018, that we had a paper presented at the French National Society Congress in 2018, where they actually presented and highlighted from the Hôpitaux, can't even read anymore. Hôpitaux in Lyon, the University of Lyon, sorry, the results with our product in cataract and in post-blepharoplasty applications. So altogether, what we are saying is that we are now capable of talking in a different way to our surgeons, to our customers, offering package of products, but mainly consultation. They don't want to hear about, doctor, this product is best. They want to hear, doctor, I have a way of helping you solving a problem that you will have now, opening up again your practice.